Good afternoon. It is my great pleasure to welcome you to the launch of our Spotlight series. My name is Dervla Morris and I am Director of the Ryan Institute Centre for One Health at NUI Galway. The One Health concept recognises that human health is linked to the health of animals and the environment we share. The Centre for One Health at NUI Galway brings together researchers and key stakeholders in human health, animal health and environmental health. As we will hear today, it is essential to take a One Health approach to tackle many of the human health challenges we face in today's world. The Centre for One Health Spotlight series will highlight some of these challenges over the coming months, launching today with a focus on COVID-19. Over the next 90 minutes, we will learn from national and international experts how threats like COVID-19 occur and how these threats can best be managed by taking a One Health approach. We will begin by hearing three short presentations by Dr. David Navarro, Professor Roberto Laragione, and Professor Martin Cormigan. Roberto and Martin will then be joined by Professor Maura Connolly for the panel discussion. If you have any questions you wish to put to the panelists, please use the chat function. So without further ado, it's my great pleasure to introduce to you our keynote speaker for this afternoon, Dr. David Navarro. Dr. Navarro is co-director of the Imperial College Institute of Global Health Innovation at Imperial College London and is currently Special Envoy of the World Health Organization Director General on COVID-19. He secured his medical qualification in 1974 and has worked in over 50 countries in communities and hospitals, governments, civil society, universities and in United Nations programmes. David worked for the British government in the 1990s as Head of Health and Population and Director of Human Development in the UK Department of International Development. From 1999 to 2017, he held leadership roles in the UN System on Disease Outbreaks and Health Issues, Food Insecurity and Nutrition, Climate Change and Sustainable Development. In October 2018, David received the World Food Prize together with Lawrence Haddad for their leadership in raising the profile and building coalitions for action for better nutrition across the Sustainable Development Goals.
It really is a privilege to join you today at this webinar organised by the Centre for One Health at the National University of Ireland in Galway. And I'm really grateful to Professor Morris and also to Dr. Maura Connolly, my former colleague in the World Health Organization, for giving me the chance to join you. I'm David Navarro, and I worked for some years coordinating the United Nations response to avian and human influenza. That work started in 2005. And because I was focused on avian influenza, and that meant working closely with colleagues from the veterinary community, I got really interested in the concept of One Health that was starting to emerge. I first found out about this from the Wildlife Conservation Society, who convened a meeting in 2004 that was explicitly focusing on how to make the world a safer place, given the threats of zoonotic diseases arising at the interface between humans, animals, and the environments in which they live. It seemed to me to make such sense. And when I looked at the Manhattan Principles that were developed at the Wildlife Conservation Society convening jointly with Rockefeller University in 2004, I found something really interesting. This wasn't just an approach to preventing epizootic and epidemic disease. It was also looking at ways to contribute to the integrity of ecosystems everywhere for the sake of humans, their domesticated animals, wildlife, and the biodiversity on which everything depends. You see, I see One Health really as a systems approach. And I think it's probably important that we think through what actually happened as more and more professionals really got interested in One Health, and they put their thinking into practice during certainly the period of avian influenza, and then when dealing with other zoonotic disease threats. You see, when we were working to help governments and others really come to terms with the threat of avian influenza, we found that the countries where we were working, particularly in Southeast Asia, were really interested in bringing together their veterinary health and human health actors. They saw the need to take a combined approach, and especially when working with businesses that were involved in poultry or involved in other domesticated animal rearing, they recognized that if at local level the animal health and human health people could come together, that would really reduce some of the threats of emerging livestock disease. So I watched the movement start to emerge at the local level, and it was particularly in Southeast Asia. But then since, I've got really interested in the potential for closer working at this interface. I'm excited by the idea of One Health thinking, and then One Health principles, One Health policies, and One Health practice. But at the same time, I've been impressed that it's not easy to actually get 2 or 3 or 4 disciplines to come together and work for common purpose. We all have our different disciplines, our different sectors, our different institutions, our different cultures, and they make it very hard for us to work together on issues, even though if we are to serve people for the best, we have to deal these issues together. And I've been really impressed by the energy of so many different groups that have actually put their efforts into bringing together different disciplines, just as you're doing here in the Centre for One Health that you've set up here at the Galway part of the University of Ireland. So let's look ahead now, and let's think, what are the barriers to getting the One Health approach more widely applied? We've got to do it. We're living through a pandemic of a zoonotic disease that's entered into the human race in a really disturbing way, and it's becoming actually endemic in many sections of our society. It's particularly affecting poorer people. It's going to be really hard to hold back, and yet we've got to do it, because otherwise the consequences are unthinkable. So as more and more countries think through what's involved in doing this, they're realizing that public health must be valued. But if we're going to value public health, we must also value the effort to protect ourselves against diseases that might emerge at the animal-human environment interface. And we must also work really hard to get that interface better understood, because that's going to be at the heart of thinking about, planning for, and then actually establishing the future. So let's look at some of the challenges and see what we can do together to make health come to life more vividly. First of all, it's what happens in the institutions, particularly the academic institutions, where professionals are being trained, whether it's as undergraduates or as postgraduates. It's important that they are helped to understand why a One Health approach that explicitly works across disciplines, sectors, and institutions is worthwhile from a societal as well as an economic perspective. And then we must find ways to bring together the different professional groups so they are actually able to work together. Here that means working on values. And there are always going to be challenges in aligning the value systems of people working for veterinary health, and people working for human health, and people working for environmental health. But if we know that there's going to be challenges over values, then at least we also know that what we've got to do is to encourage dialogue between the different groups and to make certain that dialogue is sustained, whether it's focusing on local action, on action in urban communities or subnational areas, action at national level, particularly when it comes to bringing together different ministries and sectors, and then action internationally, particularly that brings together the Food and Agriculture Organization, the OIE, and the World Health Organization. So let's do everything we possibly can to get the disciplines working together at the university level. Then let's do what we can to show that if the disciplines work together, they can add value to whatever happens in the livestock sector, to whatever happens in infectious disease management, to whatever happens in the environmental health arena. And then, once we've showed the applicability of this interdisciplinary approach, we then use it as the basis for accountability. The whole process of planning for the future has to be about all of us who have professional roles making sure that we're accountable to the people we serve. This applies whether we're working in the public sector or the private sector. Without accountability, we have no way of demonstrating to others that we're moving in a direction that will benefit them, particularly those who are still in younger age groups and who probably are wondering what on earth we are going to offer them in terms of legacy. And that leads me finally to suggest that it really is worthwhile engaging the public in the One Health movement, showing them actions that seem to be, at least from our perspective, the most appropriate to reduce risk, showing them the kind of authenticity that will help them to understand what we're talking about, not over-exaggerating the risks faced, and not, in fact, actually over-exaggerating what is possible through a One Health approach, but just demonstrating with a degree of humility and at the same time an understanding of the importance of the approach we want to take, that it is both accountable and authentic if we put the One Health movement right at front and center of policy, practice, and public information as we move forward. Thank you very much indeed for the chance to be with you.
Thank you. Our next speaker this afternoon is Professor Roberto Larragione. Professor Larragione is Professor of Veterinary Microbiology and Pathology at the School of Veterinary Medicine, University of Surrey, and Head of the Department of Pathology and Infectious Diseases, and Deputy Head of School. Roberto is a veterinary microbiologist with a particular interest in zoonotic bacterial pathogens of livestock and companion animals. His current research focuses on understanding the pathobiology of zoonotic pathogens, antimicrobial resistance, and the development of novel intervention strategies, including diagnostics, vaccines, and probiotics.
Hello everybody, my name is Roberto Larragione. I'm the Deputy Head of the School of Veterinary Medicine at the University of Surrey and also the Head of the Department of Pathology and Infectious Diseases. I'd like to take this opportunity to thank the organisers for inviting me to participate in this exciting event today. In the next 10 minutes or so, it's my pleasure to talk to you about the role of animals in COVID-19 and the development of rapid diagnostics. Of course, zoonosis is at the forefront of our mind at the moment, with 60% of existing human infectious diseases being zoonotic. At least 75% of infectious diseases of humans, such as Ebola, HIV, and influenza, having an animal origin. And 5 new human diseases appear every year. 3 of those are of animal origin. We shouldn't forget also that 80% of agents with potential bioterrorist use are zoonotic pathogens. Bringing this all together, we think about zoonotic disease across different countries. And one project which has brought all of this together is the One Health European Joint Programme. Across Europe, it's brought many different institutes and stakeholders together to study antimicrobial resistance, emerging threats such as COVID-19, together with zoonosis across the broad spectrum of the different diseases which encompass it. So COVID-19 and animals, well, it's been at the forefront of the news most days, and we've had different reports about COVID-19 in many different species. Some of the larger ones have been outbreaks in farmed species, such as mink. We've seen an outbreak in the Netherlands and more recently in Spain. In addition, there have been cases reported in wild animals and also in companion animals, such as cats and dogs. And this has raised many questions about whether COVID-19 can be transmitted from animals to animals and from animals to humans and vice versa. So the current situation regarding COVID-19 in animals is that there is evidence for SARS-CoV-2 infection in animals. A number of species have been shown to have the virus. And as I've just mentioned, there have been a number of outbreaks, some fairly large, including with clinical disease in some species. And one of those was the outbreak in mink in the Netherlands. We've also seen cases in companion animals such as cats and dogs. But of course, a lot more work needs to be done to understand the prevalence of SARS-CoV-2 in animals, both domestic and wild animals. So what is the risk? Well, what we've seen so far is that a number of different species can be infected or carry the virus. And right at the beginning of the pandemic, wet markets were cited as a potential vehicle for where the virus may be or originated from. And subsequently, many wild species have been shown to potentially have the virus. And there's been a very good report by the FAO, which details exposure of humans and animals to SARS-CoV from wild animals, livestock, companion animals, and indeed aquatic animals. However, in the press, what we see is there is currently no evidence that pets play a significant role in spreading COVID-19 to people. And this may be the case, but there needs to be a significant amount more research into this and targeted surveillance studies to understand whether animals are exposed, whether the virus can cause disease, and how it might be spread from one to another, and whether they could even be reservoirs for the virus, whether they're domestic or wild animals or even livestock. So are animals a neglected transmission route? Well, again, we don't know for sure. We've started some of the surveillance and there's some very good studies underway. However, more needs to be done to understand what species may be susceptible to the virus, how the virus may survive within those different species and how it may be spread. And there's recently been a very nice article in Pathogens published, Are Animals a Neglected Transmission Route for SARS-CoV-2? And I urge you to look at this article and read that. It really nicely details the current situation and what should be done going forward to further understand the role of animals in the transmission of SARS-CoV-2. So thinking about how we might control the disease or the virus, one such thing that may help was rapid diagnostics. And these could be employed for surveillance and epidemiology, rapid, sensitive and specific diagnosis of cases. They could be used easily in the community if they're easily deployable. They could help with track and trace systems when they're put in place, assist the healthcare workforce getting back to work, so testing them so they can go back into the workplace, and ultimately improve health outcomes. So what are the hallmarks of a good diagnostic test? Well, first, it needs to be sensitive. It must be specific. It must be rapid and cost effective. And of course, if we're thinking about it being in the environment, it must be robust. So at the University of Surrey, we've been working with a number of collaborators at other universities and some commercial companies to look at the development of a test for COVID-19. And this test has been based on the development of a loop-mediated isothermal amplification assay, LAMP. And we started off by undertaking a very detailed comparative genomic study to aid in the design of that LAMP assay. In order to ensure that it was specific and sensitive, we looked at a range of different viruses, so there wasn't cross-reactivity. And the wealth of genomic material available out there allowed that to be done in great detail. And that initial work has been advertised quite significantly in a number of talks, but also through some press releases, and you can see one here on the slide here. So it's a very simple test, less than 30 minutes. Simply take a swab, RNA extraction, and then perform the assay using a specific device which we've developed in collaboration with a commercial company. Very easy to read results. They can be read visually. Essentially, successful amplification within the assay results in a pH colour change, which is detected by the eye. Changes in colour from pink to yellow when the pH drops below 7. So you can see that very clearly at the bottom on the naked eye, or within the device in the upper plates. So as I mentioned, we've worked very closely with a number of companies to develop a deployable device, which is now in the production stages, and essentially allows this assay to be able to be deployed into many different environments and very easily used by staff with little laboratory expertise, so that it can be used in many different environments. And this is called a virus hunter 6 detection system, which has been developed, and essentially allows for the colour change. But in addition to that, we've been working with our teams at Surrey to produce algorithms. So we're including artificial intelligence component so that we can increase the test sensitivity. And that means that actually the colour differentiation between a positive and negative can be more easily picked up by the algorithm that's been trained on many, many samples. Because it's such an easy assay to use and a simple device, easy to read as well, the device can be deployed into multiple different types of environments, such as schools, the workplace, hospitals, universities, etc., etc. So in summary, some domestic and wild animals may become infected with SARS-CoV-2. Infection in animals can be asymptomatic or symptomatic. Zoonosis and reverse zoonosis may occur. However, further surveillance of domestic and wild animals is urgently required to understand the distribution of virus. We also need rapid diagnostics, which maybe will help us with surveillance and control and understanding the epidemiology of the virus. I'd like to finish by thanking our many collaborators that have been involved in the study, including other universities and the Royal Surrey County Hospital, and the companies that have been involved, and of course the funder of the original project that allowed us to develop the devices, the BBSRC. With that, I thank you for listening, and I'd be happy to answer any questions.
Thank you, Rob. So before we come to our questions and answers session, I'd just like to introduce our final speaker for this afternoon, Professor Martin Cormican. He is Chair of Bacteriology at NUI Galway, Consultant Microbiology at Galway University Hospital, Director of the Galway University Hospital's National Reference Laboratory Services, and National Clinical Lead for Healthcare Associated Infection and Antimicrobial Resistance.
Hello, my name is Martin Cormican, and thank you for the opportunity to speak to you today about COVID-19, a One Health challenge, and about some of the work I've been involved with in controlling the infection and perspectives on how that works. I find that a helpful way to think about COVID-19 is to think about these three concentric circles of what it is that we're trying to do. You can think about, first of all, preventing the introduction of the virus into a particular population or setting. Then the second line is, if the virus does introduce, what can you do to reduce the spread of the virus in that setting? And the third, and really the thing that is most important, is what can you do to reduce the harm metrics that
Apologies, we seem to be having some technical difficulties with Professor Cormacan's presentations just at the moment. We're just trying to resolve it, so bear with us for a few moments.
one of the things that strikes me about this is that we might call this a zoonotic disease, and we talk about viruses jumping the species. Always measure the issue of harm as well as we would like. So preventing the introduction globally, when we look at a new virus, of course, the first line failed globally in 2019 when the virus was introduced into the human population. One of the things that strikes me about this is that we might call this a zoonotic disease, and we talk about viruses jumping the species barrier. And those terms tend to emphasize compartmentalization of the microbial genomosphere. The One Health concept, which we're talking about today, is a much better concept in terms of emphasizing that continuity that there is, that perhaps better reflects the 21st century reality of what we have to deal with in relation to infection. Preventing introduction onto this island, of course, failed sometime in February because the virus was introduced into this island sometime in February. Hard to say when, and of course the focus here, I'm referring to the island rather than to the different jurisdictions, because jurisdictional boundaries are probably of limited consequence in relation to the spread of this virus. The first COVID case we know was detected late February, but it's clear that the virus was here for some time before that. From an institutional or a general healthcare setting, what can we do about preventing the introduction of the virus? Well, in a general setting, like for example, a university campus, then the key part of the work is to try to keep the virus from being introduced by getting those people who have infection to stay away from the campus, to stay home, for example. The challenge for healthcare systems is a bit different, because in a healthcare system, we can't prevent the introduction of the virus, because healthcare systems are where you go when you get sick. So for the healthcare system, we have to have the virus introduced. The goal is to identify those with the infection as soon as possible, to provide excellent care for those with infection, but to do so in a way that has effective infection prevention and control built into that care. And that's really important, because if we don't build infection prevention and control into the care, then the healthcare system can become an amplifier of the infection and can be an important way of spreading an infection once it's introduced. So if that line of introduction is breached, then the next step is to control the spread to the best of our ability. And important to that is understanding the spread. So this virus, we know, is shed in vast quantities in liquid particles from the respiratory tract. The virus can be detected in some other body fluids, but they're probably not really very important in the spread. When the virus leaves an infected person, the virus or an infected host, the virus must reach the mouth, eyes, or nose of another susceptible host before it is inactivated by things in the environment, including cleaning agents or ultraviolet light. That vulnerable host, of course, we know is not just limited to non-immune people, because we've also seen reports of infection of other species, including, for example, mink in some countries. Those liquid particles come from the nose or mouth in a plume. There are particles of different sizes and they're traveling at different speeds. So there's a continuum of particles. The concentration of particles is maximal at source, so the closer to the mouth or the nose, and it declines rapidly with increasing distance. So again, we have another continuum of distance and the likelihood of meeting one of those particles. The concentration of particles in the air declines partly because the particles land on stuff and partly because the particles disperse as they scatter. So there's two factors contributing to the dispersal. We think of those liquid particles in two categories: droplets, which are the bigger particles which tend to fall out of the air faster and travel shorter, and aerosols, smaller particles. They can stay suspended for a long period of time and can travel further in the air and, for example, can fill the entire room. Droplets and aerosols from an infected person can contain the virus, and droplets and aerosols from a non-infected person do not contain the virus. That it seems so obvious, you may wonder why I'm saying it, but it is something that sometimes is overlooked. I think that people think that it is the droplets and the aerosols themselves that are that spread, that are dangerous, whereas in fact it's droplets or aerosols that are charged with the virus and that are dangerous from the point of view of what we're speaking now. We believe that droplets are accepted as the key factor in spreading of COVID-19. There's been a lot of controversy about the role of aerosols, and of course in relation to infection disease there are very few cases where you can say something will never happen, but and we know that aerosol spread can be important in certain healthcare contexts, but in general terms, droplets, the bigger particles, tend to be what's most important in relation to the spread of this virus. So what happens to the virus that is scattered in those droplets? Well, it can land in the mouth, eye, or nose of a susceptible host if that host is close enough to the point of origin, so that the mouth or nose of the person who coughs or sneezes or speaks. The other possibility, if there's no host to land on, is that those droplets will land on hands of the person who generated them, and then they can be transferred to another person on hands. The other thing that can happen to those droplets is that they land on the surfaces, for example, a tabletop or a computer keyboard, and then somebody else who touches that contaminated surface can get the virus onto their hand. And then if they touch their eyes, their nose, or their mouth, they can put the virus onto the mucous membranes. Important to say that the virus does not go through skin. So contaminating of hands is important because hands can then introduce the virus onto the mucous membranes. It's very important that spread is monitored, and there's a lot of discussion of R values, and many of you will have heard of the discussion of R values. And really what we're looking at here is the idea that if you have 100 people who are infected and they result in the infection of 90 new people, well, then you're gradually winning. If you have 100 people infecting 100 people, then that's a steady state, and that gives you the R value of 1. And if every 100 people infect 110 people, then you're gradually losing. And of course, if every 100 people infect 200 new people, then you're losing very fast because the number of cases is doubling very quickly. There are some other elements of monitoring spread that I want to mention briefly. Obviously, conventional public health and epidemiology are really important. So you have to detect people who are infected, and that's based on clinical features and on laboratory testing. And you can map that incidence of infection in different parts of the world, different parts of the country, and that's helpful in understanding how the virus is spreading. We also have molecular epidemiology, so sequencing of viruses can help us also to understand the pathways of spread. And very interesting and very relevant to today's talks are the work that's going on about looking at detection and quantifying of viral genes in sewage as a method of tracking what's happening in terms of virus spread in a community. A technique I think has wide application to many infectious diseases as it's developed over the next few years. So what is it then? That's understanding spread and tracking spread, or what are the things that we do about reducing spread? And this is a very high level overview of the approaches that we can take on that. So the first one that I would emphasize is if we detect and contain sources of infectious droplets. So that's people, or indeed sometimes animals that can be infected with the virus. And if we get those to stay away from susceptible hosts, then that reduces the risk of spread. Of course, in a healthcare setting, as I said, you can't always exclude people with infection. So you can contain the source of infectious droplets using infection prevention and control practices. And we like to talk about standard droplet and contact precautions as ways of containing those droplets. We can reduce the scatter of the droplets from a source using face masks, for example, is intended to catch a lot of the droplets before they leave the nose and the mouth. Of course, they only work if you put the face mask on in a way that covers the nose or the mouth, and that's quite important that if masks are used, that they're used properly. And then the next part of this is for a susceptible host to keep out of droplet direct hit range. So by keeping distance. So keeping distance is really important in reducing droplet transmitted diseases. And then in situations where it's not possible to keep distance, using personal protective equipment, or PPE, is useful in protecting eyes, nose, and mouth from contamination. So those are broadly speaking, the approaches that we can take to reducing the spread of the virus. Another important one, of course, is that when you're in an environment where somebody has been shedding the virus may be on surfaces. So if you touch those surfaces, you can transfer the virus to your eyes, nose, and mouth. And that's why hand hygiene, and of course, keeping your hands away from things you don't need to touch, and cleaning of surfaces are important. And then another way we have for preventing spread is, of course, if there are less susceptible hosts. And that can happen naturally as a result of naturally induced immunity. And of course, what we're all looking forward to is if there is an effective vaccine. An effective vaccine will reduce the number of susceptible hosts, and that can make a huge difference to reducing and controlling the spread of the virus. The third line, and this is the centerpiece of those three circles that I showed you earlier, and the one that really matters, is preventing harm from infection. Because it's the harm that matters. If this was a virus that caused no harm, then there would be no importance in stopping its spread, and it's the harm that we need to think about, I think, all the time, rather than just the virus. So one of the things that's important is supporting the most vulnerable to that harm, to be extra careful. So we know now that there are certain groups who are more likely to suffer harm, particularly people who are older and people who have existing disease of their lung, for example, and other pre-existing diseases are more likely to suffer harm. So getting the information to people like that about how they can take extra care and protect themselves is really important. Other things that help to reduce harm is promoting general health. For example, generally healthy people tend to have less severe disease. So if you have been planning to adopt a healthier lifestyle, now is a really good time to do it, because if you do catch COVID, then the better your general health, the better the chances that you have of recovering and making a good recovery from it. Other things that are really important in reducing harm is the early detection and response to localized and intense spread. So recognizing outbreaks and the work that public health colleagues do this area is really important in recognizing outbreaks and intervening to protect people from harm in that way. Early detection of infection and access to healthcare is really important, because we know that supportive healthcare can result in much better outcomes. So access to healthcare is really important in reducing harm. And then, of course, care and support of survivors and the bereaved is important, because people who survive may have a long road to recovery, and those who are bereaved need support and in many ways from the society that they live in. there are, I suppose, two parts of preventing the harm. Of course, preventing the harm from infection is the part that I've just been talking about, and the second part of preventing harm is preventing harm from collateral harm from control measures. So there are things that we can do to control the spread of the virus that can sometimes have unintended consequences that are harmful. So it's really important, again, to focus on the harm, because placing care for the person and indeed for animals and the environment at the center of the response is an opportunity for improving what we do. It's not an impediment. I've heard some people think of this as that a sort of a rights-based approach to managing an epidemic is a barrier, that it stops you doing things. But I would argue that actually that person-centered, or that harm prevention approach is actually a positive way of keeping the focus on what really matters, and indeed engaging people with us, because we need our communities to believe that what we're interested in doing is protecting them as well as we can, if they're going to work with us in the control of the pandemic. And one of the things that's important about that, of course, is trying to make that judgment about what measures are most effective and what measures are likely to be of little or no value, because measures that are of little or no value can generate major impact on the environment and indeed on animal welfare, as well as economic and social impacts without benefits. And one of those examples, for example, is the widespread use of gloves in the general society, which are of no benefit and generate significant environmental impact. So trying to define what works and it is really important, and focusing on that. So the conclusion from me is that pandemics are hard. No one has all the right answers, and everyone makes mistakes. Perspective, evidence, and compassion are the best guides to getting through it. And I often get asked in media interviews if people should be afraid, and my standard answer is that fear doesn't protect you, but being careful does. And so fear is not your friend, but knowledge and care can be. Thank you very much for your attention, and I hope you enjoy the rest of the session.
Thank you, Martin, and thank you to all of our speakers, Dr. Navarro, Professor Laragione, and Professor Cormican, for their very insightful and thought-provoking presentations. I'm delighted to announce that we will be joined for the panel discussion by Professor Maura Connolly. Professor Connolly graduated in medicine from NUI Galway, holds a Master's in Public Health from UCD, a Diploma in Tropical Medicine from the London School of Hygiene and Tropical Medicine, and completed higher specialist training in public health medicine in London. Her areas of expertise include emerging infectious diseases, pandemic management, and humanitarian response. She worked with the World Health Organization in Geneva for 15 years, where she coordinated the World Health Organization's Disease Control and Emergencies Programme. As advisor to the World Health Organization's Assistant Director General for Health Security, she provided technical support to the One Health initiative, which was spearheaded by Dr. David Navarro in his role as UN Systems Senior Coordinator for Avian and Human Influenza. She subsequently coordinated a Horizon 2020 research project on pandemic management in the School of Medicine at NUI Galway, and she is currently Public Health Advisor to the Department of Health in Ireland on the COVID-19 response, and Adjunct Professor of International Health and Development at NUI Galway. So please continue to submit your questions via the chat function, and I'll do my best to get as many of those to the panel as I can within the next 50 minutes or so. So Maura, we might start with a question directed at you. With regards to preventing new zoonotic viruses from emerging, what do you think we can learn from the One Health approach that countries, businesses and agriculture in Southeast Asia took following the avian influenza outbreak?
Okay, thank you, Dervla. Thanks for the introduction, and thank you for the opportunity to participate in this event today. We can learn a lot. There are those that say if wet market regulations were more stringent in China, we may not be where we are. I think the reality is that there are probably thousands, if not hundreds of thousands of microbes out there in the animal world that pose a threat to humans. And or the animal-human interface is hugely important to monitor. And even with the best will in the world, it's very hard to predict where the next threat would come from. Certainly the work that I did with WHO, it was very clear that emerging infectious diseases was very much at the top of health policies in Southeast Asia. And you see by the response from countries like South Korea and Vietnam, these countries have very well organized systems. And as you mentioned, certainly after the H5N1 avian influenza series of outbreaks, these countries really ramped up their public health infrastructure, their testing capacity, their contact tracing ability, and were able to have a very successful response to the COVID-19 pandemic. We still look to countries like South Korea and Vietnam, Taiwan, other countries to see how the virus can be controlled with a very engaged community and a very strong, robust public health system supported by the healthcare system. So I think what we can learn from these countries is that we have to remain vigilant. The One Health approach, as Professor Cormican spoke about, the compartmentalization of our sectors and our disciplines is not the real world. And we often can be very comfortable in our specific disciplines. And this work requires to counteract these microbial threats, requires close work between the veterinary and the human health specialists. And as David Nabarro said, this is the origins of this One Health approach came from the H5N1 avian influenza outbreaks in 15 years ago. And Dr. Margaret Chan, who was the Director General, who was in Hong Kong at the time, was very instrumental in controlling H5N1. So they've been at the cutting edge of emerging infectious disease approach. And with culling of animals, culling of poultry being a rapidly implemented measure that managed to bring H5N1 under control. So I think the bottom line is we still learn. We can learn from Southeast Asia. And I think the COVID-19 pandemic has shown that we were fortunate in SARS-1 in that it was a disease that you became sick before you became infectious. So you're actually sick with the virus 5 days before you became infectious. And we managed to get away in 2003 with 8,000 cases and about 800 deaths. And that was because public health measures managed to control that. Dr. Gro Harlem Brundtland was the Director General at the time, and it was a heroic effort to internationally control that. The reason SARS-2 has got out of the box in a way is because of its capacity to have asymptomatic and pre-symptomatic transmission. And I suppose the only positive thing is that in terms of harm, as Professor Cormican spoke about, we're looking at a disease here that has a mortality rate of between 0.8 to 1%, as opposed to SARS, which had a mortality rate of 10%. And a related virus, MERS, has a mortality rate of 33%. So, and the differences between these viruses is very small in terms of its molecular makeup. So we have to remain vigilant. One Health is an extremely important movement, and we need to encourage all disciplines to be involved in it and to engage the public, as Dr. Nabarro said in his initial address.
Thank you, Maura. You've referred there to the important role of animals in many of these pandemics that we've experienced before, including COVID-19. Rob, maybe if I could come to you next with a question. What, in your view, should be done to understand the role of animals in the transmission of SARS-CoV-2?
Well, I think the first thing is we need to improve the surveillance. We need to have a surveillance system. We need to use some of the testing that we're using in humans to actually understand where the virus is, what the numbers of virus are in those animals, and is it in their environments? Is it being spread from them? I also think that we need to learn a lot more from some of the outbreaks that have been undertaken. And there's some wonderful publications out there, particularly from the outbreak in the Netherlands in mink, where we're understanding about the biology of this virus in animal reservoirs. And understanding that better will allow us to be able to be in a position where we can predict what might happen if it gets into other animal species. And every day we're seeing different species being infected. I've just seen another press release today that's come up in cats as well. So I think being ahead of the game, as we've said, with the whole human side of it, and being able to see what's out there is most important. We need extensive surveillance to understand what species might be more susceptible, what species are likely to just be asymptomatic, which species might be symptomatic, and what levels of virus might be spread.
That's great. Thank you, Rob. A question from one of our participants to the panel, and maybe Martin, you might like to address this. How do you feel as science communicators we could better relay the message to the public that this is a genuine virus and not something that may have been created in a lab somewhere?
Yeah, well, it's one of the big challenges about this, I have to say, from my point of view, compared to anything that we would have dealt with before in relation to public health, is the way social media has evolved over the past 10, 15 years, and the competing sources of information. And I think really difficult for many people to figure out who they can trust. So I think that to some extent, what we have to get better at is building that trust before there's an emergency, and so that it's there when things happen. I mean, on a positive note in Ireland is that I think that by and large, the surveys we've been doing is showing that actually there's been an increased trust within Ireland in sort of official sources of information from the health HSE and so on. So I think that that's been positive. I think the Department of Health and the HSE are seen as, by most people, as reliable sources. So I think you have to build that, continue to work on it. And I suppose the challenge for us is the challenge of communicating. I think, again, reflecting a little on what Maura says about our comfort zone, is sometimes in technical language and minutiae as it appears to others. And there's the real challenge for us to actually just speak plain English and speak truthfully. And I think one of the big challenges of science communication overall, not peculiar to this, but overall science communication, is that we're seen to be impartial, because I think a lot of people think that we tend to spin the science for our own agenda. So I think it's a long piece of work. And of course, fundamental to all of this is building the understanding of science from the ground level up through all the educational system, so that we have a reasonably science literate group of people. Because trying to fix this on the hop, and I think you've seen this in some countries where there's a profound distrust of government agencies and a kind of a culture of conspiracy belief, trying to deal with that in the middle of a crisis is extraordinarily difficult.
Great. Thank you, Martin. So to build on that, Maura, how do you think we might better be able to raise awareness of One Health among the public and make them aware of the concept of One Health?
Okay, well, I think an event like today is very important in terms of reaching out to the public, and it's a great to hear that the event was sold out and there was such demand for it. I think we are dealing with, this country particularly, the levels of trust. A recent study done across Europe has shown the level of trust in Ireland was higher than a lot of the other member states in terms of trust in government, trust in the healthcare system, trust in healthcare professionals, and trust in messages from nurses, doctors, pharmacists, for example. And as Martin said, I think we're also dealing with a very well-educated community in terms of their understanding of science. And I think when you look at the science events and Science Week that kids in Galway have been to over the last number of years, we need to be bringing One Health into that. If you look at the movement, looking at climate change, I mean, it has really captured the minds of a lot of younger people who are saying, you know, this generation, or my generation, you know, you haven't taken the issue of care of this earth as importantly as it should be. And you know, building on the activism of you know, young youth groups in advocating for protection of the planet, I think that's where One Health has a voice as well. So I think it's a very opportune time. It's unfortunate that we've had to go through such a difficult event in societal terms as this COVID-19 pandemic. I mean, I've been working in this field for 25 years, and you did at some time, in many stages during the last 25 years, you felt like you were Chicken Little, saying the sky is going to fall in and nobody's paying any attention. And David Nabarro will attest to that. And it was Gro Harlem Brundtland that actually brought the whole issue of emerging diseases to the defense community and to heads of state. It wasn't just a health issue. So the origins of One Health was really that it's David Heyman working on emerging diseases in the 1990s, and then that evolved then into the whole realization that animal health was intrinsically linked to human health. So we've been given the greatest wake-up call, I think, that we've had since the 1918-1919 influenza pandemic. And it behoves us all to learn the lessons, to ensure that our animal-human interfaces are better monitored, particularly in high-risk areas like Southeast Asia, where certain practices are risky. The slaughtering of bats and civets and other animals, this could have been avoided. And so we have a global interest in ensuring that the One Health approach is pushed from the people, that it's driven by communities, it's driven by the public, that we have a responsibility as health professionals, as veterinary surgeons, as academics, as laboratories, research scientists, to protect the health of the whole planet. And that includes humans and animals, and also protect our environment. So I think there are those more expert than I in terms of how we get the message across. My experience of the last 6 months of the COVID-19 pandemic is that we have seen very impressive leadership from our government and from our civil servants. And I'm very proud of seeing how this country has responded to the pandemic. As Martin said, it's never perfect. No response is perfect, but we've done a lot right. And I think we use this as a platform, that platform of trust, to engage younger populations. David Nabarro spoke about our youth and encouraging them to look at policies and practices of One Health and look at the accountability behind that. So I think that there's lots of work there. We have an audience, I think, for the first time in my career. People now understand how important emerging infectious diseases are. They understand how important the animal-human interface are, and they understand how important environmental health is to our sustainability as a species.
Thank you, Maura. And you mentioned the human-animal interface there. Rob, are you aware of any veterinary clinics who are testing companion animals or livestock for COVID-19, or which animals do you feel might be most important in passing infectious diseases indeed to humans?
I'm not aware of specific organisations that are testing, but I know a lot are working towards that and are very keen to be able to do it very quickly. They've certainly looked at the logistics of being able to do it. Certainly from my perspective, those animals going into the food chain and being in close contact in environments where it's conducive for transmission of the virus would be ones to look at first. We've seen that in companion animals, the virus can be in those animals. We don't know exactly what happens from a pathogenesis perspective, but it would be very interesting to know what the levels of virus are, particularly in households where humans have already had an infection as well, to look at, particularly, as I mentioned in my talk, the possibility of a reverse zoonosis as well. We're seeing lots of these cases where a number of individuals have been infected and in close proximity with animals, and then an animal has become infected, asymptomatic in most cases, subsequent to the human infection. And now it's very difficult to work out where the transmission has occurred and in what direction. But I think with some testing of those animals, that would be possible.
Great, thanks, Rob. Martin, a question for you. How soon realistically could we expect a vaccine to be available for the general population?
Yeah, I'm reminded of one of these old things I think it was Yogi Berra who said making predictions is hard, especially about the future. I think realistically, there's little chance of that happening until at best late this year or sometime next year. And I think one of the big issues will be then if we do get a vaccine is trying to prioritize who gets it first. And that's going to be a really important challenge. And a huge challenge, I think, for global health equity and for within country health equity, because one of the things that I think is very disturbing for all of us is the extent to which some of the approach that some countries have taken to trying to lock up the vaccine supply or control the vaccine supply. So I think when will we have it? I think as far as I can see, it's likely to be late this year at best, I would have thought. I don't know what the others think before it's likely to be widely available, probably next year. And then, as I say, I think there's a huge challenge of that if we do get it, making sure that the people who need it most are the ones who get it first, which will be a real challenge for us, I think, in Europe and the world.
Great, thanks. Did any of the others want to comment on that?
Just to say that I agree from the timescale. I think we're definitely looking at next year, and most important is how the distribution occurs and the channels for that. But yeah, I'm definitely looking at next year.
Great, thanks. Martin, you mentioned the issue of how COVID-19 is transmitted. How effective do you think face masks are in preventing the spread of infection?
Well, face masks have been accepted from the outset as being of value in preventing the transmission. So standard infection prevention and control advice for droplet transmitted infections has pretty much always been that you should wear a mask if you are infected, and if you should wear a mask if you're looking after somebody who is suspected to be infected or who is known to be infected. So to that extent, mask use is and always has been well accepted. As with a lot of infection prevention and control issues, of course, evidence for many infection prevention control issues is not the role of masks for wider use in the general population and in people where there's no clinical concern, no specific concern about COVID. And there's a very clear government policy on that now. I think it continues to be an area of research, but the government has made a very clear recommendation in favour of mask use now. So I think that we have a clear decision on that. But I think there will be continued research in this area over the next few years, and it's one of the areas in which there is a need for further research, because one of the challenges of science communication is communication. It's much more difficult to communicate the science when the science is uncertain, and it's much easier to communicate the science when you've got really good evidence for what it is, what the message is. So I think it's really important for us to continue to build the evidence, because it just makes that message much more clear cut. And I think one of the challenges for all of us in this area is that as scientists, we do need to debate with each other about issues where the evidence is not as strong as we would like. But on the other hand, you have to manage it so that there is, the best clear consensus that we can come to, that there's a clear message that we all agree on, that is the message we're trying to deliver. And I think that's sometimes quite difficult because, as I say, infection prevention and control, the nature of it is that generating the strongest evidence we would like is often difficult. So I think we're going to hear a lot more debate about this in scientific circles, but I think at the moment there's a very clear policy position, which is that a widespread mask use when you can't maintain social distance is currently favoured as helping to control the spread.
Thank you. Rob, another question for you. How is industrial farming contributing to emerging infectious diseases, such as potentially COVID-19?
Yeah, it's a really interesting question. I think firstly, we have to think about just the intensification of farming. The numbers of animals and our proximity to them certainly contributes to our exposure or potential exposure to emerging infectious diseases. I think in addition to that, in many countries, we're seeing a change in the environment, whether that's deforestation or more human beings entering into the wild environment and then being in contact with animals that have new and emerging viruses which could cross the species barrier. I think also the way that some of these animals are being raised and that interaction right the way through the food chain can lead to closer interaction between human beings and higher numbers of human beings traveling from different types of livestock farms from one to another that can result in subsequent spread of infectious diseases and really the mix that occurs when we see an infection go from one animal to another and then perhaps jump the species barrier. So I think it's a really important area that we need to keep a very close eye on and not just think about how we improve production, but how we improve the biosecurity, both for the animals, but also for the potential of transmission of infections to humans.
Apologies, I was muted. Maura, a question I'll direct at you. Is there concern with the impending flu season approaching and the potential for the virus still being very much present with us and the worry around that?
Well, that's a very good question, and it's a question that we're looking at the Department of Health Modelling Group, which is chaired by Philip Nolan, the president of Maynooth University. So what we're looking at is possible models of an increase in the hospitalization rate of about 20% and an increase in intensive care unit admission rate of about 10%. Now these are all models and predictions, so we really don't know. What we do know is that where a person, whether it's patients who've had co-infection in the Southern Hemisphere, that's been associated with poorer outcomes. So patients who are infected with both COVID-19, with the SARS-CoV-2 virus and influenza A, that they tend to be sicker and have worse outcomes. So it's not a good thing to have both viruses. The second concern that we have is that it will be difficult to diagnose, to differentiate between the symptoms of influenza, seasonal influenza, which happens every year, and COVID-19. There are a number of diagnostic tests, and perhaps Rob can speak to that in more detail, but there are a number of assays, multiplex assays that can diagnose both influenza and SARS-CoV-2, the virus that causes COVID disease. Detect both those viruses, but the availability of that, I think it's in the US at the moment. So what we're trying to do in this country is there's been a decision to vaccinate children between the ages of 2 and 12, all children in the country, a campaign to ensure that all healthcare workers get vaccinated and that the standard advice that all over 65 and people with an underlying medical condition that they get vaccinated. We really don't know what to expect. What we will see though is because of our interventions, because of our infection prevention and control measures, it's likely to reduce the transmission of influenza. We saw that during H1N1, where people were more vigilant, engaged in more hand washing. So it's likely that the level of the transmission that we saw last winter won't be replicated. But having said that, it is likely that our healthcare system could be overwhelmed, and it could possibly be more difficult than the first wave if they coexist. So perhaps Martin would like to add to that, but from a modelling point of view and from an epidemiology point of view, we really don't know what to expect. All we know is that it is very possible that both viruses could circulate at the same time and that they can co-infect the same person, and particularly in older age groups, that will lead to real challenges in terms of clinical management, and the potential for harm is greater with this co-epidemic, which is likely to happen. And in terms of the when, looking back at flu seasons in the US and in Europe over the past 20 years, the peak tends to be January and February. But you can get seasonal influenza viruses can start circulating as early as October. So I think we're just waiting to see, and what is really important is that what we're trying to do within the modelling group is to have an early warning system so that we know when it's necessary to go into a COVID mode again, if that's necessary. And we may avoid it. Perhaps Martin has something to add to that from the clinical perspective and the microbiological perspective. But we really, I think it's one thing that we've all had to deal with, so much unknown and evolving science. And I think our colleagues in WHO have done a remarkable job in being very, just very careful in what they advise. And when they don't know something, that it's clearly, we don't know. Science is evolving on a weekly basis with this virus. And we will continue to learn as the influenza season approaches.
Thank you, Maura. Martin, did you want to add to what Maura mentioned?
I think one of the things that struck me when Maura was speaking there is that one of the most important things is that we have the ability to say we don't know, because there is a lot of uncertainty. And I think one of the mistakes that we've made in the past around science communication is thinking that we have to have an answer, and then giving an answer, which then we lose public trust. So even though the don't know is sometimes quite hard at the time, in the long term, being as honest as possible. Thing is, Maura mentioned there about this, is that the infection prevention and control measures are actually the same for both viruses, essentially. So that what we're doing to control one will have to control the other. And there has been very useful advances in the diagnostics, and there's some other work going on in it about trying to make sure that essentially that you, as Maura referred to there, that you run a duplex test, and that you I think it will be important if we're seeing a lot of flu. We will want to know, is it flu or is it COVID? Because it will make a difference to how you manage the patient in terms of the therapeutic management of the patient, as well as everything else. So it is important, and the platforms for doing that have improved really quite a bit, and hopefully we'll be in a position to do that reasonably well if we have a bad flu year, and hopefully we'll get lucky. More than lucky, I mean, I've heard it said that in the flu season in the southern hemisphere has not been as bad as expected. I hope that's true, and if everyone is doing the hand hygiene and the distancing and all of that, then we should see less flu, one would hope.
Thanks, Martin. Both Martin and Maura referred to the diagnostics, Rob, and obviously you gave a very nice presentation on the approach you're taking. Can the work that you're doing be applied to animals, to test animals for the presence of COVID-19, or indeed use a multiplex approach to test for more than one infection at the same time?
Yeah, absolutely. Our aim all along has been to ensure that the test was very specific and sensitive, but we have looked at a range of different viruses, so that can be used in animals, and it can also be used as a multiplex test, so that it can pick up other infections, so more likely to be there's a good uptake of the test, and we hope that very soon we will be using our own test in animals. That was our intention.
Great. Actually, this might be one for you as well, Rob. And we've had a question from a participant suggesting that the global lockdowns have resulted in an anthropause, which has led to a change in animal behaviour. And what's your opinion on how this might potentially increase or decrease future risks of zoonotic transmission?
I think this is a really interesting area, and one where we need to study much more. I think the lockdown has actually brought a lot of people into the countryside, and actually that's brought individuals walking in the countryside where they wouldn't normally. I know in my own area, I lived in a very rural area, it became extremely busy overnight. Individuals you'd never seen before were all of a sudden in the countryside in droves of individuals. And I think that in itself is interesting, because you bring individuals in closer proximity to wildlife, and actually it's probably made wildlife retreat in some areas rather than be on the periphery of areas of built up housing, etc. However, the other side of the coin is that we've seen less cars on the road, we've seen less air traffic, we've seen less ocean noise and pollution, and that would most certainly have resulted in movement of animals. And I think what's going to be interesting is the tracking of what happens with things like roadkill, because that will be very telling as to whether there's been a change in animal behaviour, and actually we see all of a sudden an increase or decrease in those roadkills. But I personally think it could work both ways. There could be an increase or a decrease, and it probably depends on the area and the type of animals within that particular area.
Great, thank you. Another question from one of our attendees: what are some important lessons learned from the response to the COVID-19 that can be implemented in future pandemics? Maybe Maura, you might want to take that.
Okay, what lessons have we learned? We've learned the importance of public health and contact tracing. The measures that were used in the Middle Ages to quarantine people, the origin of the word quarantine came from 40 days in Venice, where merchants were required to stay in the bay for 40 days. So I think that's one crucial area that what we realized is that countries that had a strong public health infrastructure managed this response very well. So countries like Portugal, Greece, Cuba, in addition to Southeast Asian countries, had a very robust public health system linked to a highly developed laboratory system. What else have we learned? Looking at countries like New Zealand, Germany, very good communication. I think we've learned about the importance of leadership and the importance of political systems. And David Nabarro spoke about a systems approach. One Health is one system, it is one example of a systems approach. We also, Martin and I and Rob, we'd be looking at this world of pandemic response from a different angle. But at the core of it all are systems of political leadership. And what we have found is countries where women have led in terms of heads of state, they have managed to get a lot of trust and community goodwill around the globe. And you've seen other countries where there hasn't been the same level of trust and the same level of accountability and responsibility. So I think for me, going forward, our political systems need to be very responsible, need to be able to communicate effectively, and need to be accountable. You can't fire a virus, you can't talk your way around it, you can't buffoon your way around this. This is a natural event that will overcome us if we're not vigilant and careful. And I think the last lesson that we've learned is the importance of trust and the importance of the community and the humility that David Nabarro spoke about. As scientists, I think we've seen people being very upfront, that includes colleagues in the World Health Organization who say we don't know the answer here. So in the olden days, the doctor told you what to do and you did what you were told. Now there is more of a dialogue, and it's not perfect. I think we are losing out some traction with younger adults, the younger age group, and particularly currently with the pandemic, what we're seeing is an increase of numbers of cases in that age group of 20 to 30-year-olds. So I think there needs to be work there. And how do we engage with that age group who may not be tuning into national radio or listening to the 6 o'clock news or tuning into the Department of Health press conferences, which have been hugely informative. I think Leo Varadkar was, he managed to walk that line very expertly in terms of his reference to Mean Girls and The Hobbit, and he got a certain kudos and traction among that age group, and we need to build on that going forward, because while the potential for harm is in the much older age groups, and generally people of that age are either asymptomatic or have a very mild illness, the impact is enormous in terms of the potential for spread to older populations as society opens up over the coming weeks.
Thank you. And maybe we still have some time, one final question for the panel. Again, coming in from one of our participants, they indicate there are some studies that indicate previous exposure to common colds or the adenovirus may provide some immunity to COVID-19 or less or worse outcomes. Does the panel have any thoughts on this?
I think there's been some, I've seen some nice research on this, Derla, and there does seem to be some good immunological evidence that I've seen of cross-reactivity between.
Oh, I think Martin may have frozen.
And I wouldn't put it any stronger than a suggestion, maybe, but there is, I think, some suggestion that that one of the things that may reduce the impact on children may be the fact that they've been exposed repeatedly to seasonal coronaviruses and that they have a degree of acquired T-cell immunity as well as antibody to it. So it is an interesting one, and I think one that is quite important in terms of understanding the biology. I would just, if I could just make a comment also on the previous question, because in terms of what have we learned, I mean, other things that I've been very struck by, I must say, is, and I don't know what Maura's view on this would be, but, you know, should we be more willing earlier to reduce our human hypermobility at the site, when there's an early indication of the problem? Because I think we are the animal that brought this virus all over the world in a very short space of time. And it's related to our societal penchant for we move around a lot. And I think it maybe is appropriate to ask, both in terms of infectious disease as well as in terms of the wider environmental issue, is if we should continue to move around as much as we do, and whose interest is served by that. I think that's one of the things that I hope we will reflect on coming out of this, although I'm not necessarily confident that we will. And I suppose the other big thing that I'm struck by is the importance of, when we talk about the collateral harm issue in relation to outbreaks, is we need to be better at taking care of the people who are harmed by the steps we take to control the dissemination, and in particular, the consequences of many of the things we've done for children, and particularly for people with intellectual disability and other types of disability, and people in disadvantaged, particularly if schools, for example, are often the ways we channel all sorts of benefits and supports to people who are in very disadvantaged sections. So I think one of the other things that I think we need to reflect on at the end of all of this is, could we have done better about making sure that those who are already most disadvantaged were better protected from the measures that we took to try and prevent the spread of the disease.
Thank you. So finally, maybe just one question to all of the panel. So there's a spotlight now on One Health, and we're trying to enhance that spotlight here today. How do you think we can best build on the impetus we have at the moment through initiatives such as our own Centre for One Health and also the One Health European Joint Programme that Rob referred to? What do you think we should do now to build on this? Might start with Maura again.
Well, I think today is a very good start. I think more community engagement is important. I think that as we reflect on the last 6 months and what has worked and what hasn't worked, how do we institutionalize the things that have worked? One with the point that Martin raised there about the travel ban, I would completely agree with him. I think that the origins of that was really the international health regulations with the World Health Organization 2005, where there was a concern not to have too severe an economic impact on countries. So a travel ban was considered not necessary at the outset of this pandemic. And while introduction was inevitable at some stage, with reduced travel, perhaps it would have been a more staggered introduction to countries. So I think that's something that needs to be looked at again at the global level. And so in terms of vulnerable groups, I completely concur. So that there are vulnerable groups that really, the schools, people in certain schooling situations, people of in terms of lower income groups have struggled and continue to struggle. I think that's the other issue. This isn't over yet, and the economic impact of this is going to last for another 6 or 12 months. So we need to be looking at that. So how can One Health support this? I think there are many levels. I think advocacy at the political level. I think in terms of academic publications, making sure we work together. I think there needs to be a real drive. We now have a seat at the Security Council. We've got a very expert team in Washington and New York. The potential to bring environmental health issues and animal health issues to the forefront politically. We have a platform now and a very good reason to do this. And Ireland has been very active in the field of climate change. So we need to use that platform. So I think it goes from high level global advocacy down to teams working together within the One Health group, within the Ryan Institute here in Galway, working on academic publications, ensuring we get word out, the information, the science. We've got science behind or the facts that we send around, or knowledge. And I think we need to engage with the younger, student body and school kids in terms of One Health. It's a holistic approach. It moves on from the compartmentalized disciplines that are essential to achieve excellence in a specific area, but it's not how the world works. The world works with huge interaction between multiple systems. And what we need to do is make sure that the next generation of scientists and academics understand and see the world as intrinsically and intricately linked together.
Thanks, Maura. Martin, did you want to comment?
I think Maura's covered it very well. I think it's keep communicating, keep talking, keep trying to generate ideas, and I think that thing of trying to bear in mind. I think again, one of the expressions I've been taught by one of my colleagues in the last year is manage up. So while we have to try to influence at every level, I think trying to get key decision makers to see that One Health is going to make life better for people is something we need to continue to and better for animals as well, actually, is one that we need to keep pressing on with. Yeah.
Thank you. And finally, Rob.
I agree with everything that's been said. I think the only thing I'd add is that the projects that we're involved in, I think we really need to showcase those. We're in a situation now where those projects have come to life. We've got a spotlight on us, infectious diseases. There's a wonderful opportunity to raise the profile, and particularly as has been said, with the younger generation, to actually see how exciting the work that we do is and how it influences worldwide economies, health, and of course One Health across the whole planet. So I think we have a wonderful situation from a perspective of putting forward our own expertise now and showing how important infectious disease and all the disciplines that play into it are.
Thank you, Rob. So that brings us to the end of our webinar. Unfortunately, we're now out of time. So I just wanted to say thank you to all of our speakers and all of our participants in today's meeting. So thank you to Dr. David Navarro, Professor Roberto La Ragione, Professor Martin Cormican, and to Professor Maura Connolly for joining us today. This event would not have been possible without the Trojan work of the organising committee over the last number of weeks. So thank you to Dr. Liam Burke, Dr. Louise O'Connor, and Dr. Sinead Duan, and the Ryan Institute Communications team, in particular Isabel McLaughlin and Nora O'Halloran. As I mentioned at the start, this is the launch of the Ryan Institute Centre for One Health Spotlight series. So please keep up to date on future events in this series and indeed other Centre for One Health activities and wider Ryan Institute activities by logging on to our website, following us on Twitter via Eventbrite, or dropping us an email to onehealth@nuigalway.ie, and indeed the Ryan Institute email address also. A recording of this webinar will shortly be available on our YouTube channel, and we look forward to seeing you virtually or maybe in person at our next event. Thank you all.
Thanks, Julia.
Thank you.
Thanks, Dervla.
Thanks, Maura.
Thank you.
Thanks, Rob. Thanks, Martin.